Hi, this is Dr. Alice Lee. Welcome to iCubed. iCubed is EMN's latest blog, and we are very excited that you're here to join us. My hope is really to try to impart some knowledge to my fellow clinicians, as well as instruct in patient care, and mostly I really would like to inspire excellence in our day-to-day practice of emergency medicine. We're not academics, most of us are clinicians, and I just hope with this screencast that we can all inspire each other and encourage each other to practice excellent emergency medicine and bedside care. Well, I have a new guest this month, and I'm very excited that he's joining us. Why don't you introduce yourself?
My name's Bill Fulton. I am a board-certified emergency medicine physician. I actually grew up in Apache Junction, which is about 10 miles from where we practice.
Wonderful.
And I went to Arizona State and then University
Wonderful.
of Arizona for medical school.
I didn't know that.
Yeah.
All these years, I've known you
All
so
these
long.
years, yeah. I'm a homeboy. And then I did my residency in Cleveland. So I'm a
wow.
Cavs fan and I'm
Fantastic.
a Browns fan. Unfortunately, I don't win too many games. And, I love to coach. I'm married, been married for 30 years.
Oh, wow.
And I have 4 kids and 3 grandkids.
Wonderful.
So that's what I spend a lot of my time doing.
That's fantastic. Well, it's been a pleasure working with you all these years, Bill. You're a wonderful example for our young doctors. So we'll just jump into this case.
Okay.
Now, those of you who have been following this screencast know that we work at a retirement area and a community, so our patients are mostly retirees. He's 80 years old, and he comes in with the chief complaint of his gums bleeding.
Okay.
So 5 to 6 days before he came in, he had 8 teeth taken out.
8. Okay, that's good. It's a good number.
8 teeth taken out, and apparently it was not a problem until just about 2.5 hours before he came in, and he had taken his dentures out, and then it started oozing and bleeding, and they tried what they could at home, and it just wouldn't stop bleeding. So they came in sometime in the evening, probably about 9 o'clock. It's pretty busy.
I think that's kind of how it goes in emergency medicine.
Yes.
When you have a case where you might need some backup that you don't have in the hospital anyways,
Yep.
they're going to come in late at night.
Naturally.
Makes it even more troublesome for you.
He tells you he's on Xarelto and Adempas. Have you ever heard of Adempas?
I have not heard of the Adempas.
Yes,
What is that?
me neither. I quickly looked it up. It's for pulmonary hypertension.
Okay.
Anyway, with Xarelto, there's some trouble here, right?
Right.
Xarelto, he's going to be bleeding more than normal.
And I think with our hospital, most of the patients that we see are elderly, like you've already said, and they're
So
going to be on a number of medications. A lot of times they're going to be on some of those anticoagulants, so it's going to make it more challenging.
He's got obstructive sleep apnea, has a history of DVT. Really nothing out of the ordinary for our patient population, right? This is very common to see those.
And I think one of the nice things that we like about working at our hospital is we do really take care of a lot of sick people.
Yeah.
And when you're an emergency medicine provider, that's what we like, right?
Yes,
nothing wrong with
absolutely.
taking care of earaches and runny noses, but we like taking care of very sick patients. That's what we get to do.
That's why we stay here.
That's why we stay here.
So this 80-year-old's on Adempas and Xarelto, baby aspirin. He's on metoprolol, Lasix, spironolactone, potassium, lovastatin and donazepam. He's got some eye drops. So really a list that's pretty common in our patient population. Continuing with his exam, this is his set of vitals. Even though he's been bleeding for hours, he's actually pretty stable.
Yeah, vital signs look good. There's nothing there that really makes you nervous just looking at that.
Makes you jump out at all. So on physical exam, let's just try to visualize this gentleman. He's actually able to converse and talk with me, tell me what's going on. And so we focus on the mouth. Now, I'm looking in his mouth. He doesn't actually have any lower teeth. You can see on sort of the left anterior and lateral, all the way around, he has these sockets that are kind of briskly oozing blood. There's some sutures that I can see. You can look on his neck and you can see this sort of purplish bruise all the way down. So he's been kind of bleeding underneath the soft tissue, but it's down here into the anterior left side of the neck, as well as right under the submental area.
Now, did his dentist, did he stop the Xarelto for any time, or did he just do the extractions?
Right. In terms of his Xarelto, I believe he stopped it for a day and then restarted it. Now, you wouldn't know if that was good or bad unless you knew the half-life. So actually, Xarelto has a very quick onset. Within 2 to 4 hours.
Nice.
It'll be fully therapeutic. And then the half-life is roughly 5 to 9 hours.
Okay.
So they tell you to hold your Xarelto for about 24 hours before the procedure, but then you can go back on it pretty soon, right after the procedure.
So that's nice, and that's one of those. That's why we get to use that medication now for DVTs.
Yeah.
Remember when we started, DVTs all got admitted to the hospital.
Yep.
And again, being an old warrior like I am,
we are.
When you say you can send those people with DVTs home, you're a little bit nervous, right?
Like,
That's not in your practice.
I know. I'm not attending PEs home.
Yeah.
I'm like, I got to read up a little bit more about the data on that.
Yeah, exactly. But that's good to know that the rapid onset of Xarelto. And the nice thing is it's a once-a-day med, so that helps us out too.
So a lot of the cardiologists, they just say, just give them one and then they can go home for, let's say, AFib or something like that. Because they know it's going to kick in no time. So the more we kind of know about these drugs, the more we're comfortable as emergency physicians with what the consultants are asking us to do, right?
Yeah, absolutely. Absolutely.
So let's timestamp this visit a little bit. He comes in at around 9 o'clock.
Okay.
Right? And he's already oozing. We put a wad of gauze in there, just have him bite down on it, right? And
that's kind of what we learned in, first aid, right?
Yep.
Pressure.
Yeah.
But I think sometimes we forget those basics they're basics for a reason.
Yeah.
And pressure is always very important. I remember years ago when I rode horses to school. I was in residency.
You rode horses to school?
No, I'm teasing you. But I did grow up in Apache Junction, so it's a good story to tell. So I had this patient that had this bleeding AV fistula.
Oh, wow.
It's in the ICU. I'm a resident. It's only me.
Oh, geez.
And he's bleeding. And so what does a hotshot resident do? I do a suture.
You did?
And then guess what happens? Instead of having one bleeding hole, I have 3. So I'm a slow learner. It's 2 o'clock in the morning. And so I try another suture. Now I have 5.
No way.
And I remember thinking there's no cavalry coming.
Exactly.
And so what did I do? I took my right index finger, gently, right? Because you can't hold real heavy pressure. I held pressure for about...
Because it's a fistula, you wanted to.
About 15 minutes, and the bleeding stopped.
No.
And so that is burned into my memory that pressure is important. So that's exactly what you did here in this case, is pressure. Pressure is always important if you can do it.
That's a great story, Bill. I love that. Yeah. So on this guy, we start off with just basic things. It's just direct pressure. So he's got this wad of gauze, and he's biting on it. It's not doing a thing. I go back, half an hour later, it's still oozing. I go another half an hour, I go back to oozing.
Yeah, blood.
He's not having any respiratory issue.
Oh, that's good. And he's not swallowing because we know that's going to start vomiting.
No, he's just biting on it. He's very lucid, very cooperative guy. He's in no distress. He's just bleeding.
Nice.
So I'm like... You're kidding, right? So it's got to be the Xarelto. And in the meantime, I'm looking at Adempus. On the website, it talks about maybe a 2% severe bleeding and hemorrhage risk.
Oh, good.
Yeah.
Good. And then just for the trifecta, we've got baby aspirin, right?
Yes.
So we've got all kinds of issues we've got to work on at 10 o'clock in the evening.
So I had heard about Tranexamic Acid for the past few years. Have you heard of that? Do you know much about it?
I don't know much about it, and I've never used it. When you look over the algorithms, that is one of the things that they talk about.
Yeah, I have been hearing some things about Tranexamic Acid over the past couple of years. So it's like, okay, let's try it. So
nice. Now, obviously, as an ER provider, was that the first time you were going to try that?
Yep. My impression from the previous conferences I had gone to was that it's very, very safe.
Okay, that's
overall.
Nice.
So it's one of those, it's not going to hurt you. Just try it,
So that's nice.
It may help you. So I called the pharmacy. I asked what they had. And so I kind of MacGyvered it,
Okay.
So let's look at the timestamp.
I love MacGyver.
Exactly. So I've given him an hour plus.
Yeah.
Right? So I call the pharmacy. I get him to send me 1 gram liquid Tranexamic acid. I take half of that and I soak it in gauze and have him bite down on that for half an hour.
Okay.
Right? So we do that. I go back. You can see the timestamps that I have in the chart here. I did it again the second time with the other 500 milligrams. Still oozing.
Still oozing.
So now we're 3 hours into it. He's still bleeding from his mouth.
And so what I think about when we're seeing this is, this patient's giving us a trouble, but this isn't the only patient you probably have, right?
Exactly.
And now we're starting to kind of lose focus on other patients, and this is the hard thing about emergency medicine, right?
Oh, totally.
We have this patient that we got to keep focusing in on. We've got and it's at night, so we have less coverage.
Yep,
so
right.
it makes this case even more challenging.
Exactly.
For us.
So intersecting with these timestamps, you have imagine as emergency physicians, we've got the other patients, whether they're critical or not, and in fact. Here in our hospital, many times those other patients are critical.
Exactly right.
Yeah. So.
Exactly right.
So now 3 hours into it, he's bleeding this whole time. I say to myself, I probably should get some labs.
Well, it's one of those cases you're thinking if I get it stopped within half an hour, the guy's out the door. Yeah. So I don't think anybody can fault you with that.
Right. So labs. Now I get my labs.
Okay.
So fortunately his hemoglobin is 10.6, but we all know that first H&H really isn't always reflective of the actual body, the actual lab, because he just started bleeding a few hours ago.
Right.
He's here bleeding in the ER. So this test, although it's reassuring, it's not definitive in terms of how much he's really lost, right?
Well, and so we've tried conservative, we've tried compression, we've tried this new medication topically. That's not working. He's still oozing. So that we have to keep escalating, right?
So we're in a community hospital.
Right.
We don't have all the subspecialists we need, and so fortunately, Banner has set up a way for us to have the help and consult of the specialists. So we call our outreach, center. And
it is nice that Banner has that transfer center now where you can make one phone call or put it into have them work on it for us. Because again, you're still in a very busy ER at night, limited coverage. You're working hard.
So at the end of my shift here, I had to hand him off to my next my colleague, the next EP. So then later on, apparently, our dear Dr. Vasquez, who took over, gave him PCC due to the elevated INR, which is appropriate.
Sure.
So they got a blood test there at about 3:40 in the morning. Now we're dropped from 10.6 to 9.4. It's reassuring, but he's definitely been actively bleeding.
Yeah,
he's lost a unit just in that period of time in the ER, both in our ER and the ER down there.
Right. A little bit concerning.
Yeah, the dentist that was consulted, I like the fact that he wrote here, this bleeding cannot be stopped by pressure alone. Yes.
Nice, right? So that helps us know that we were doing everything we could do.
Yeah. It helps me because that's exactly why I sent him. I didn't, we don't want to be perceived as wimps, I guess.
Right. Well, and it's nice. It's nice to be validated when you're doing everything you can, and obviously you did. You were working your way through this case.
Yeah, exactly. This is how the dentist fixed the problem.
Oh, so he sutured Surgicel. Okay.
So he took Surgicel, put it over the wounds that were oozing, and he sutured it down tightly with a binding
so kind of a combo technique, right? So he did pressure with sutures and Surgicel. So interesting.
Now, when I read that, I thought, why didn't I try Surgicel on this guy? I had Surgicel in my pocket.
I wasn't thinking Surgicel either, so it's good to kind of talk through this case and say, hey, don't forget these basic things that we have tried before. So very simple for him because he's done it.
Yeah.
We don't do that.
And we don't think about it.
Don't think about it.
But now I'm going to think about it.
Right. I am too. And don't forget Surgicel, although I don't carry it around in my pocket.
Yeah, I do. I have things in my pockets. Wow. I was always waiting. Now I've got a little opsites to put over the eye when I do an eye ultrasound. I've got the earwax curettes that I can pull earwax out.
So now I know your jacket's always a little bit unbalanced.
It's a
lopsided jacket. Okay. Not your fault.
Exactly. All right, so that was the case. Not terribly critical, but it's a more and more frequent type of patient that we're seeing in the ER with all of these senior citizens being on just all these new anticoagulants, right? So for each of my iCubed screencasts, what I want to do is have 2 learning focuses just to sort of streamline our teaching points in the screencast. So my first learning focus for this patient, how do I stop the bleeding?
That's important. How do I stop the bleeding?
So I listened to Alma Matu's podcast faithfully, and a few months ago he had actually last year I think, he talked about this very important article in the Western Journal of Emergency Medicine that I've used multiple times. The title is Anticoagulation Reversal and Treatment Strategies in Major Bleeding, an update an update of 2016.
So this is nice because it's pretty recent.
Oh yeah,
right? Pretty
this
recent.
is a really, really important article. And these two charts are absolutely critical in our management day-to-day of anticoagulants. Now, when I look at charts like this is what happens in my head.
Yeah, mine too.
So, to help us all, this is a phrase that our dear Dr. Harper has said a few times. Just keep it simple, stupid. So I have gone through the article pretty thoroughly and try to simplify it for us to try to help us remember. These are our conventional oral and parenteral anticoagulants. All of us old dogs know.
Yeah,
right?
oh yeah, we've heard of these.
Heard
of these. We've grown up with these.
Yeah, exactly. And then we've got these new ones, right? They're called NOACs or DOACs. They're new direct oral anticoagulants. Number one that I remember that came out was the Pradaxa. So Pradaxa, Eliquis, and Xarelto. Now, I'll give you a little tiny pearl. The Eliquis or Apixaban, Xarelto, rivaroxaban, these two have an X in them because they are anti-factor 10.
I like that.
Chemicals.
Got the X.
So you'll remember that versus dabigatran. It works on a different part of the coagulation cascade. So we got the old ones, and then these are the new ones. Now.
Oh, here we go. So we got 3 slides we have to remember. All right. We got to be an elephant. All right.
Keep it simple,
keep
stupid.
It simple.
Right?
Keep it simple. I like it.
All right. So our first slide. Memorize this one. Pradaxa has a reversal agent. Prac Spine.
And I like that because the first 3 letters are the same, right? So we got a shot on remembering that one.
I'm going to test you. Pronounce this word right here.
Yeah, that looks like somebody did a Scrabble board and threw that in there. I'd like to know how the pharmaceutical companies come up with these names. I mean, this is almost schizophrenic.
I'm very proud of myself. I know how to say that. It's idarucizumab.
Can you say that 5 times fast?
No.
Okay, but very impressive for one time.
Idarucizumab. There you go.
Very
okay.
Nice.
Anyway, Prac Spine is for reversal of Pradaxa. You ready for slide number 2?
I am. I love that one.
Number 2, protamine sulfate is for the reversal of heparin.
You know, I'll never forget this because I had a vascular, actually, as a cardiothoracic surgeon, came down, patient was on heparin, and early in my career, and they wanted to reverse the heparin, and it was protamine, and he, like a lot of our cardiovascular surgeons, was pretty impatient.
Yes.
And so protamine is one of those that, definitely have to remember that one.
Yep.
Definitely have to remember that
Exactly. Now, I have never had to give this in my long career, but it's absolutely important because the heparin is still around all the time, all over the place. So we have to remember it.
And it might be one of those things where you start it and you have to reverse it. So you definitely should remember this.
Right, because heparin toxicity can definitely be fatal. All right, number 3, this is your third slide. 4-factor PCC is for the rest of the anticoagulants.
So I love these key points. This is how I like to remember things. I like to remember the key things, right? Because if we can remember a certain number of things, we're in good shape. If not, we won't remember any of it. So these are excellent points.
Yeah, so memorize those 3 slides. You got it? And then you can check it up. You know, if you need the specifics, you can check it up. But these are very important topical thoughts in your head.
Yes, yeah.
You like the elephant on the corner?
I love the elephant. Yeah, it helps me remember.
So, idarucizumab.
There she is. She snuck that word in again. I'm very impressed.
So, let's talk a little bit about Prac Spine. So, it only, like we talked about this, it only works on dabigatran. And it is actually an antibody. And it binds to the Pradaxa. So, it makes it ineffective, right? So, the Prac Spine is effective at reversing or neutralizing the Pradaxa within minutes.
Now, I've never had to use this. I know one of our providers has used this. Have you ever personally used this? You have had to use it once. Okay.
Yeah. It is not used very often. I'm on the hospital's P&T committee, and just earlier this spring, we talked a little bit about different anticoagulant reversal agents, and this is one of those we use in this hospital, but it's not very often.
Oh, interesting.
Yeah. So then, in the studies, the hemostasis was reported as being improved without increasing thrombosis, which is a safety feature, of Pradaxa. Prac Spine. Now, you were starting to talk a little bit about it, but the advantages of the 4-factor PCC is that the clotting factors in this compound is 25 times more concentrated than FFP.
That's a pretty impressive number.
It's really impressive.
Pretty impressive number.
And that's why it reverses your Coumadin toxicity within 15-20 minutes, right? The other advantages, it's available right away, IV. They just have to mix it up in the pharmacy. They can send it down. With our senior citizen population who have so many cardiac issues, it's really good to have the PCC because it avoids the volume overload that so many of them cannot tolerate with the FFP, right?
Absolutely.
And then there's the rare but definite complication that you may see with transfusions, which is the transfusion-related acute lung injury. Then the disadvantages, there's a small prothrombotic risk for it.
Well, and I think when we're using this is kind of that life and death case,
yes.
right? These are patients where you've got to stop the bleeding. It's
Correct.
usually, for me, it's always been the head bleed.
GI bleeds.
Yeah, GI bleed's another good one. I mean, you have to stop the bleeding, or the patient doesn't have a chance.
Yep.
So I think that's the thing.
Intraocular bleeding is another one.
Yeah.
And any kind of bleeding in an enclosed space, right? Like the brain or the eye. And then the cost is sometimes prohibitive for some institutions,
right.
It's sometimes 2.5 to 10 times more than the FFP. All right. So focus number 2.
Now you're going to have 3 slides for this one?
I'm going to touch on tranexamic acid a little bit. It's just kind of become more fashionable recently in emergency medicine to talk a bit about this. The most important thing that I learned as I researched this was that it does not actually reverse the anticoagulant.
Interesting.
Yeah.
Interesting.
So how does it work, right?
Yeah.
Well,
you're going to tell us.
I'm going to tell you. I'm going to do the Fibrinolysis for Dummies slide.
And I'm hoping you have this really busy slide that we have to look at here just to confuse us. Take us back to medical school.
No.
Get us ready for the boards.
I'm a very simple person, very down to earth kind of person. So I got.
And that's what we love about you, Alice. Yeah. That's what we love about you.
So here we go. Fibrinolysis chart for dummies.
I like that. I think there's a book. I saw this at Sam's Club the other day.
Yeah, it's my next book.
It's not a big seller, but it looks really good.
So, fibrin is the clot, right? So you make a clot, and then plasminogen and plasmin make FDP or fibrin degradation products because they cut clot down into little pieces essentially. Right? Yeah. So where does tranexamic acid work? Well, tranexamic acid works right there. It stops the plasminogen and plasmin from working. So what it does is keeps the clot from dissolving.
Okay.
So if you're bleeding, your body naturally would form clots, right? So when you put the tranexamic acid IV or topically, what it's doing is keeping your body from breaking down its clots.
Okay. All right.
There you go.
Nice. I like it. Like simple concept.
For dummies. Yeah, exactly. Yeah. So one final point, what dose will we use, or what dose should we use? Well, I don't exactly know, but recently a major study that kind of propelled tranexamic acid out to the ER sort of consciousness really is this CRASH-2 trial.
Love the name of that, right? I mean, that's a whole...
It's totally appropriate.
Yeah, totally appropriate, and that's important to just be able to name something.
Right. CRASH-2 trial had 20,000 trauma patients in multiple facilities. And what they did was give 1 gram of IV tranexamic acid, or TXA, within that first 8 hours of the traumatic injury. Okay. And then they gave another gram IV over the next 8 hours. The reason I bring this up is because since they did this and it was safe, it's probably safe to give a gram topically. So this is my simple-minded thinking of the safety of the drug.
Okay.
Use 20,000. Here's 20,000 patients that got IV tranexamic acid or TXA, and I'm sure I can give 1 gram topically without any problems. Now, it didn't work on this gentleman, unfortunately.
Right.
But in terms of dosing and the safety of it, I think that we should all be comfortable with giving 1 gram. So in this screencast, I wanted to introduce our listeners to TXA. It's become more and more in the consciousness of the ER doctors in the clinical setting. And for me, this patient was the first time I actually even tried it. Even though it didn't stop his bleeding, it became part of my in my toolbox. I put it in my toolbox now that I'm more and more familiar with it.
Which is important to have, because sometimes if our toolbox has one tool, that's all we ever use, right?
Yeah.
So it's important to have multiple things. Yeah. And if that one tool doesn't work, now what are we going to do?
Exactly.
So it's good to have multiple things.
Yeah.
Which is one of the fun things we all went into emergency medicine for, right? Exactly. Just solving problems that other people not sure what they do.
Exactly.
And sometimes we're not sure either, but we're going to do whatever we can to make it better.
Very good. Well, Bill, I really appreciate your time. You've been great.
I've enjoyed our time.
Yeah.
Thanks for having me.
Yeah, you're very welcome. Thanks, everyone, for listening this month, and we'll see you next month. Bye.